Medication can also be a barrier for someone with a dual diagnosis. Medication can sometimes be effective, and thinking about our everyday lives, sometimes it works, sometimes it doesn't. Sometimes it works for you, sometimes it doesn't work for me. Um, but it needs to also be described or prescribed appropriately. So often with a dual diagnosis, we're actually seeing more medication ineffectiveness, and that's because of the following reasons. They were misdiagnosed from a doctor or psychiatrist. There's too many medications prescribed, not enough medications prescribed. There's unintended side effects from the medications that they're taking. Medication administration errors happen. Now, this could be a caregiver not giving the medication correctly or not at the right time, or we could see a poor adherence from the individual themselves. They're not taking their medication, they forgot, they don't know where the medication is. A lot of the reasons, though, that someone with a dual diagnosis is taking medications actually has to do with their behavioral issues and physical issues. So again, going back to a couple of slides ago, we were talking about how sometimes in the intellectual disability field, we're not seeing a lot of talk about someone's mental health or the symptoms that they are displaying because of their mental health. Instead, we talk about, they're having a challenging behavior, they have a physical problem. So that's really where we're seeing a lot of the medications. Doctors do have a harder time correctly diagnosing someone with an intellectual disability for multiple reasons. Some of them is communication barriers. Individuals are far more agreeable. The lack of experience working with someone with an intellectual disability, and then diagnostic overshadowing, which is what we're going to be going over next. So diagnostic overshadowing is defined as determining someone's major diagnosis and trying to fit all their symptoms into that diagnosis only. Sometimes this is unintentional. Sometimes this is intentional for different reasons. But an example would be someone with autism is diagnosed by a physician. However, that person is also exhibiting bipolar disorder. The physician might attribute the symptoms of the bipolar as more symptoms of the autism. Therefore, the person never gets diagnosed with bipolar and never actually gets treated for that bipolar either. So some difficulties for diagnostic overshadowing reasonings would be communication barriers or miscommunication, not understanding the person, not having clarification, nobody else helping with the advocacy with this person. Individuals that have an intellectual disability tend to be far more agreeable or suggestive. So when they are in a doctor's office and the doctor says, it seems like you're exhibiting a lot of anxiety right now, the individual with an intellectual disability is far more agreeable. They're like, yeah, sure. And usually it's because they don't quite understand what you're saying, or they want to make you happy, or they just want to agree with you because it's easier. The lack of training for clinicians, doctors, and therapists for someone with an intellectual disability. We're seeing a spike in the right trainings and the right clinicals being put into place, but we still have clinicians, doctors, and therapists that are in the field right now that are not trained to work with this population. So we're seeing some diagnostic overshadowing because of this. Actually, I sat on a panel, and I'll tell you a quick story. I sat on a panel for Temple University 2 summers ago, and they were asking us about, what we see in the field as providers and what we would like to see. And basically what came out of this panel was Temple University trains doctors, and they were talking about the training that doctors go through to work with this population for intellectual disabilities, and they only got 6 hours of actual time to be trained on working with someone with an intellectual disability out of their 10 years. So we definitely identified that as something that wasn't working in the field. And actually Temple started implementing more and more training and classes on how to work with this population. as well as partnering with some of the providers to do clinicals. So they actually got the hands-on working with someone with an intellectual disability experience, which was great. So getting back into our diagnostic overshadowing. There's delays in getting treatment. There's a lack of understanding where to go for treatment for someone that has an intellectual disability. And then number 5, problems with identifying and separating the symptoms from physical issues. So I'm going to tell you another quick story. This is kind of what has to do with number 5. When I was managing an adult training facility, we had an individual who had a doctor, a PCP, primary care physician, for like 40 years. I mean, this person went through her entire adulthood. She had them forever. And we see that when that happens, we get a little bit of complacency. But this doctor was told by us and her residential home, hey, she's having some problems in the afternoon. She tends to get upset. She's pinching people. She's very hostile towards her staff. She just doesn't seem happy. She kind of just wants to be left alone, and she's chewing on her fingers. And so the doctor, at the doctor's appointment, was like, okay, well, it sounds like she's having a challenging behavior. And to us, we were like not really understanding. Sure, it's a challenging behavior, we get it. But he was saying, no, that's it. That's the reason. So we're going to prescribe her a PRN, which is as needed, medication for when she's not doing well. So we leave the doctor's office and we have this PRN, and the whole team is talking, and to us we weren't really satisfied. That wasn't just it. She wasn't just having a challenging behavior. This was new to us. This is something that she was exhibiting to us, and she couldn't communicate with us with what was going on. So actually, the residential manager was like, listen, I'm going to go get a second opinion. She takes her to another doctor who is a primary care physician, and they say, well, let's run some tests. So this doctor ran some tests, and we get the test results back, and lo and behold, this individual actually has a reflux disorder. So she was exhibiting all these challenging behaviors, I'm saying it in quotes, because she was in pain and discomfort. She was putting her fingers in her mouth and not happy with staff and not happy with others around her because she was trying to tell us something. So that is one of the biggest things that we do see with diagnostic overshadowing, is that complacency and just saying, oh, I'm sure it's just a challenging behavior, and especially with this population. We really want to look into, is it a physical issue? Is there something else going on? The next barrier that we're going to talk about is drug use. Substance abuse, alcohol, and drugs are actually not as common for someone with an intellectual disability as you would think. Substance abuse for someone who has an intellectual disability only comes in about 7%. Now, jumping down to the third little star down there, substance abuse for someone who has a dual diagnosis, so intellectual disability and mental health combined, is higher. And it's usually due to their functioning, environment, mental health issues, and the accessibility to those substances. So that percentage actually jumps to 20%. So that is pretty telling of the differences. That's 13% difference. Now, someone with an intellectual disability, they have recently stayed home with caregivers or family members, and so that usually provides a great deal of monitoring and modeling behavior. So that's usually why we see the 7% is a little lower. However, there is a small population of individuals that did not grow up in that type of environment, or they were released from institutions and kind of fell through the cracks. So that might be where we see some of that 7%. Also, some individuals with an intellectual disability are living in an environment that might have somebody that already is using substances in the home, and we will see that percentage jump there too. The individuals that do start using substances that are dually diagnosed have a harder time with addiction. And the reasons are pretty much the same as going to the doctors. They have a limited understanding and lack of cognitive awareness. They have a harder time seeking out services. The services that they do find don't meet their needs for someone that has an intellectual disability. Their communication issues aren't usually the same. So we see a lot of those communication barriers not getting broken down in these treatments. So sometimes they can't read, or they can't comprehend language, or they need more processing time. So these services really aren't geared for them. So we also see that individuals have a lack of social skills. So maybe the groups or the individual therapy just really isn't hitting them like it should. And then that lack of processing time in groups or therapy sessions as well. When you go to drug and alcohol treatment, usually your sessions are like a couple times a week, and you have like 45 minutes to have a discussion with your therapist, and then that therapist usually gives you some homework or stuff to do until you go back to the next session. When you're working with somebody with an intellectual disability, that 45 minutes might be too long, it might be too short. They might not be able to do the homework on their own. Some of the drug and alcohol stuff that we do see is 12 steps. That individual might not be religious, or might not even understand what that religion is, or they can't read that stuff on their own. So we do see services with drug and alcohol not meeting the needs correctly. And then the last one, lack of control. So going back to executive functioning, it's limited with someone that has an intellectual disability or dual diagnosis. So they have a harder time with decision making, execution of goals, staying on task. So we do see that somebody that has an intellectual disability or dual diagnosis that has a substance abuse, usually it's for life. They have a really, really, really hard time kicking the habit. The last barrier we're going to talk about today is forensic. So forensic issues are committing crimes, being in prison, being on parole, probation, getting in trouble with the law. So that's what we're kind of going to be discussing right now. So most of the time, people with an intellectual disability and dual diagnosis are actually the victims of a crime. However, there is a small population, like with substance abuse, that actually do commit the crimes. When this has happened in the past, people with a dual diagnosis were sentenced to prison like any other person. However, in other countries right now, they have looked at therapy and hospitals and rehabilitation instead. What they've been finding, and especially in England and Australia right now, is that someone with an intellectual disability, oftentimes when they're committing the crimes, don't even understand the crime that they committed, why it's a crime, and why they're being sent to prison. So they're not really learning anything. So other countries like Australia and England are now putting into place these therapies, rehabilitations, and hospitals to try to get this person to understand what they did and how they did it, and how to avoid doing it in the future. So some of the reasons that someone with an intellectual disability or dual diagnosis is getting in trouble with the law or having forensic issues is because of poverty, poor role models, little to no support, poor executive functioning, past abuse and neglect, or trying to fit in. Most recently, it was found that people with an intellectual disability, not dual diagnosis, just intellectual disability, attribute for about 4 to 10% of the prison population. Now I want to talk about this statistic because it's 4 to 10%. That's a huge amount of leeway, right? The problem that we were having and still are having is prisons don't have a way to say this person has an intellectual disability, this person doesn't. They don't ever differentiate. So the data that we're pulling is really just on self-identifying data. So that 4 to 10% is kind of giving that leeway, saying we think there's a little bit more, but the data that we pulled in 2013 is not really cutting it. There have been more calls for research, and we'll talk about it on the next page. But we're not really getting anywhere. Our prison system in America doesn't really have that much data on intellectual disabilities. However, it is reported that most prisons cannot effectively treat those with a dual diagnosis and don't always have the means to identify those who have a dual diagnosis. So not even just intellectual disability, they're also having issues with combining the intellectual disability with that mental health. So we do see a lot of problems with the prison system and probation and parole with the dual diagnosis population. So forensic issues, there's a lot of issues with individuals being wrongly convicted or imprisoned as well. And so we do see some of the population that is in prison right now might not actually be the one that committed the crime. There have been cases, and you can look up cases and go down a rabbit hole. I'm only going to talk about one specific one today. But there have been cases where people have been wrongly convicted or imprisoned because they didn't understand, or the following: they're trying to hide their disability, they are agreeing with police officers, and this could be a couple different reasons, but the most common one we see is they're usually afraid. They're often at scenes of crimes because of curiosity and often blamed because there's something wrong with them. Of course they did it. There's something wrong with them. They don't understand their rights, such as their Miranda rights. If anyone's been arrested, they have to give you your Miranda rights, which is basically reading you the rights of you as a citizen. You have the right to remain silent. You have the right to an attorney. Anything you say can be used against you in the court of law, that type of stuff. The police officers rattle that off. So someone with an intellectual disability doesn't have the time to process what's being said to them and if they want to comply with what is being said to them. Sometimes when they're being questioned by police, they try to run away or they act strangely. There was just a really good Netflix, I guess, show series. It's called Atypical, but in one of the episodes, they had someone with autism walking down the street, and a police officer stops him because he's beyond curfew, and he starts acting strangely. So the police officer actually thinks he's drunk or on drugs and arrests him. So that is something that we do see in our society, is not understanding the intellectual disability or autism and the effects and how it's going to make them react whenever they are, questioned by police or chased by police. And they're easily blamed. Overall, it's easy to say, we don't understand who this person is and they don't understand what they did, but they probably did it. People with a dual diagnosis are more likely to reoffend than someone who just has an intellectual disability. Not a lot of research has been done in the US, which we talked about on that first slide. But UK, like England and Australia, they've been doing great things over there. They've been doing a lot of research. Again, they've been doing that rehabilitation and therapy and trying to get people the right information. There have been more calls for research, clinical data, and collaboration with prison systems for someone with an intellectual disability and a dual diagnosis. So I'm curious to see. I pulled the data in probably a couple months for 2017, 2018, and I'm really, really hoping, fingers crossed, that we have more data and that we are working on more programs like England and Australia, where we can say we are going to work with these individuals and rehabilitate them.